Treatment of PDR in advanced stage needs vitrectomy. Vitrectomy for PDR involves clearing of medial opacities like vitreous hemorrhage, creating a proper plane of dissection, separating the posterior hyaloid from retina to expose the vascular epicenters, and dissection of pre-retinal membranes to relieve retinal traction. The pre-retinal membranes in these eyes are sometimes associated with second membranes, which is said to be due to schisis of the posterior vitreous. Meticulous dissection of all these membranes is required to achieve a good postoperative result. After removal of epiretinal membranes, residual vitreous is removed. A second layer of vitreous is again separated from the retina. This layer is due to schisis of vitreous. Complete shaving of vitreous is done to the vitreous base. Proportional reflux is used to disperse and remove the pre-retinal blood. This completes the vitrectomy, and the only thing remains is the streak of preretinal blood in the periphery. After spending a considerable time on procedure so far, we often tend to ignore this peripheral blood. But is this a sign to ignore? In this video we will try to see if this peripheral lining of blood is of any clinical importance or not. Once we started teasing this hemorrhage, we found a small opening. After a little more effort, we were able to peel another layer of vitreous from the retina. It was a surprise to see the amount of vitreous still present in the eye. Let's see whether this is a one-time phenomena or not. This was another patient with vitreous hemorrhage and TRD. A thorough vitrectomy was done. Vitreous was shaved up to the base. A streak of peripheral pre-retinal blood was seen. On applying suction at this blood streak, vitreous membrane was separated from the retina. This membrane is quite adherent to retina and requires some effort to peel it up. The peeling has to be done from anterior to posterior rather than posterior to anterior. Another case with PDR, vitreous hemorrhage and TRD. Plane of dissection was created by peeling the membrane over the disc. Pre-retinal membrane was dissected and removed. A thorough vitrectomy was completed. Peripheral pre-retinal hemorrhage was seen. Again, a layer of vitreous was separated from the retina by peeling the vitreous from anterior to posterior direction. This is another case in which a modified en bloc dissection was done. All pre-retinal membranes were peeled, dissected and removed. A very thin innocuous streak of hemorrhage was seen inferiorly in the mid-periphery. On teasing the membrane again, a layer of vitreous was revealed and separated from retina. This is a case of combined retinal detachment. Preretinal membranes were removed. Preretinal blood was cleared from the macula. Even ILM peeling was done. While doing vitreous shaving, a thin peripheral blood lining was seen. Triamcinolone was injected to stain the vitreous. The layer of vitreous was then peeled off from this peripheral blood line. In the last, just to show how tough it is to remove this layer of vitreous, vitrectomy was completed, and a layer of organized vitreous hemorrhage is seen in the periphery. This hemorrhage alerted us to the presence of vitreoschisis. Active suction was applied in the periphery, but this layer could not be separated despite much effort. Triamcinolone was injected. Triamcinolone was able to stain the vitreous at the disc, but the PVD could not be induced either with the vitrectomy cutter or soft tip cannula or even with forceps. ICG dye was used to stain the ILM. ILM peeling was initiated. Only then, the removal of vitreous layer was possible. In the end, it could be said that the presence of peripheral streak of hemorrhage means incomplete removal of vitreous. This layer of vitreous is tightly adherent to retina and may need the use of triamcinolone or peeling of ILM to separate it. Active suction should be applied in anterior to posterior direction to peel this layer. Peripheral blood lining is not a red herring and cannot be ignored. It may be a sign of vitreoschisis. It is a red flag.